Today, we're going to talk about diabetic ketoacidosis. And this concept is broken up into a number of parts. And in this video, we will discuss the pathogenesis as well as the clinical features of DKA. And my disclaimer is that this video is not a comprehensive review, but rather it's just a concise snapshot of the key features involved in the pathogenesis and clinical features. So let's start. And we're saying that DKA generally begins with some trigger. And it's often a condition that it's secondary to some other event. And so from this trigger, we have a cascade of other events that is occurring, and it could include a state of relative insulin deficiency or insulin resistance. And the cells of the body, they really believe that they are in a state of starvation. And so even though we have glucose, sufficient glucose around, the cells cannot access it because insulin is either not present or it's just not working well enough to facilitate glucose entering inside the cell. And so as a result, all the physiological response mechanisms of stress and starvation, they get set into motion, and hormones like your cortisol, epinephrine, glucagon, etc., all of these predominate in order to stimulate glucose formation, or something we call gluconeogenesis. And a key player in this movement of gluconeogenesis is your fat cells. And there's where we have the process of beta oxidation, lipolysis, and as well as ketone body formation. And so in this slide, really, we could appreciate the features of DKA. So we have hyperglycemia due to counter-regulatory hormones. We have ketone body formation, of which you can see there are two types, the acetone as well as beta hydroxybutyrate. And this results from the process of lipolysis, which is a driving force in the condition. And as well, lipolysis it's going to be a main target for insulin therapy. And of course, we have acidosis, which occurs, and this is as a result of ketone body formation, which just happens to be acidotic in nature. And so, as we mentioned before, when speaking of DKA precipitants, we spoke about the triggers. And so triggers gives us an idea of what type of condition could send a patient into DKA. And on top of that list is infection, because it's the most common. And other common precipitants could include your non-compliance as well as de novo diabetes. And we know that a percentage of your type 1 diabetic patients, they first present with DKA. And then following this is changes in insulin regime. You also have myocardial infarctions, and these could really precipitate a DKA. And certain drugs like antipsychotics and thiazide diuretics, as well as steroids and some beta agonists, can also precipitate DKA. So with regard to your clinical features, these patients, they could present with the regular polyuria, polydipsia, and this is because of your hyperglycemia, as well as dehydration is also as a result of hyperglycemia, which leads to hyperglycuria and an osmotic diuresis, and this could leave your patient volume depleted. And so now we're seeing nausea and vomiting and most of these other symptoms, which also including Kussmaul's respiration, as well as your acetone breath and even abdominal pain. These things are coming from ketone body formation. Things like altered mental status can be due to the effect and severity of the acidosis present, and it could also be altered mental status, that is, could also be a sign of cerebral edema, and cerebral edema is a complication of DKA. And so then we should also pay attention that a patient with DKA is also likely to have some underlying precipitant, because we spoke about triggers. And according to what that trigger or what that condition can be, it could overlap the symptoms that is present, or it could also extend the type of symptoms that we're expecting to see in classic DKA. So in this video, we try to encapsulate the key players in the pathogenesis, as well as to illustrate some of the main clinical features in DKA. And this really brings us to the end of part 1 in this concept. And you can look out for part 2, where we are going to discuss the investigations as well as the diagnosis.